Today, we are going to talk about atopic dermatitis, also called atopic eczema, a common chronic or recurrent inflammatory skin disease that affects about 15% of children and about 7% of adults worldwide. To discuss atopic dermatitis, I am excited to chat with Dr. Amy Paller, a pediatric dermatologist who serves as a Chair of Dermatology at Northwestern University Feinberg School of Medicine. I am particularly interested in skin diseases that affect children. So I am elated to have you, Dr. Paller, on the Derm Club podcast today because you are a world expert on pediatric cutaneous diseases. I would like to emphasize that Dr. Paller is a recognized researcher, writer, and editor in the field of dermatology, with over 525 publications. She has co-authored one of the most important textbooks in dermatology called Hurwitz Clinical Pediatric Dermatology, and also serves as the Director of Pediatric Dermatology Clinical Research at Northwestern. She has led almost 100 clinical trials. She is well known for her research in atopic dermatitis, and some of her recent research has helped define the immunophenotypes in early atopic dermatitis in children, paving the way for new targeted therapies. Welcome to the Derm Club podcast, Dr. Paller. We're so glad you're here and joined us today.
Thank you so much for inviting me.
So let's start off by talking about atopic dermatitis, of course. And can you first help define atopic dermatitis? Because many people are often confused. Should I call it dermatitis? Should I call it atopic dermatitis? Should I call it eczema? And people are so confused. Is it one or is it all the same?
Well, thanks, Hannah. That is such an important question. And I just want to stress that eczema is a group of disorders that show eczematous changes and is not just atopic dermatitis. In fact, the community of experts has written about this, stressing the need to give it the proper prefix. Atopic dermatitis in the UK, for example, it's more commonly called atopic eczema, but very important not to just call it eczema, except perhaps when you're talking to the lay public, because that's what they know it as. And in that case, saying the proper name is atopic dermatitis. The reason for this is beyond just being precise. It is because, unfortunately, there are ICD codes that are totally different for atopic dermatitis and eczema. And if someone calls it eczema and codes as eczema, it's not going to be the same code as for what it might truly be, atopic dermatitis.
Oh, it's very helpful. So how do you differentiate atopic dermatitis from eczema?
Well, again, atopic dermatitis is a subset of eczema. And in fact, in children, the most common one that we see. The diagnosis of atopic dermatitis is really a clinical one. This is not a diagnosis we generally consider taking a biopsy for, unless there is another disorder that is identifiable by biopsy that one is seriously considering. So we look at the clinical features, the characteristic of the eruption, that it is eczematous, that it has certain distributions that may be age-related. Certainly the associated itch is an important feature. And then we might consider other aspects, for example, that history or family history of atopy and a variety of other features.
Can you discuss the clinical presentation for mild, moderate, and severe atopic dermatitis?
Sure. I guess that the best way to talk about that is that we have scoring tools like the Investigator Global Assessment that help us to put someone into these various categories. So it's based on how red the skin is, perhaps how oozing, crusting it is, just the various characteristics like that are part of what makes an eczematous manifestation, that depending on the degree of those can be classified. With the most recent validated Investigator Global Assessment, we need to bring in as well the extent of involvement, because you really can't have someone with severe disease that is very localized.
What is the physiology behind atopic dermatitis? Is it one thing, or are there many
Can
causes?
I go back to the last one for a
Of
minute?
course.
I think it's important to note that even though these global assessments and the type of physician assessments that are out there for clinical trials are very much focused on the physical findings, it's so important that when we consider mild, moderate, and severe, we take the patient's reported manifestations into consideration as well. Itch is cardinal. I think it's incomplete if one has a visit and doesn't at least get some quantification of itch. Sleep is the other potential factor that's really of critical importance in questioning a patient about. So the itch, the impact on quality of life, the impact on sleep are other important considerations. And in fact, there are some scales that do take them into consideration, like the SCORAD has questions for the patient or for the family and the young child about itch and sleep. And I really like the very easy 7-question POEM, the patient-oriented eczema measure, which can be completed by children who are, let's say, 8 years of age and above, sometimes even a little bit younger if they're more mature, or by the parent, and gives you a score that takes into consideration physical as well as patient experienced changes of the eczema. We need to be inclusive, and we can't just look at physical signs in making that decision.
So you really need the whole story.
We are holistic in our practice.
Very important. And it's obviously very important to have the parent or guardian there to help give that story, because otherwise you can't just get the whole picture.
Well, in the younger kids, there is always one there, fortunately.
So will you talk a little bit about the physiology behind atopic dermatitis?
Sure. So the pathomechanism of the disease is one that we are still doing a lot of research on, but it's very clear that it reflects the interplay between the barrier impairment, which relates to both lipids and various proteins, the microbiome on the surface, and then, of course, cardinal to what's going on is the skin immune alteration. Central to this is the skewing towards that Th2 immunity, and often, and particularly in children, the reduction then in the Th1 axis. And this is all seen in the skin, but also one can find evidence of it in the blood as well. There are some differences with age. We see a different picture in terms of some of the barrier abnormalities and certainly some of the immune abnormalities, particularly this deficit of the Th1 axis that's throughout childhood. But what we do see, regardless of age, are the increases in the Th2 immunity, particularly IL-13 and to some extent IL-4 and other cytokines and chemokines of that pathway, and also increases in IL-22 are consistently seen across the ages.
So it sounds like there's really an array. It's not just one thing. Is there a difference between intrinsic and extrinsic atopic dermatitis?
That's a very good question. I'm not even sure that there truly is an intrinsic versus extrinsic form. The majority do have elevations in IgE, and if they don't, I don't know that that truly should be classified as a different form. There's not good evidence that the morphology is different. There's not really great evidence that there's any difference to the same kind of approaches in terms of turning it around. There has been some suggestion of Th17 being a differentiator in terms of being more increased in the intrinsic. But personally, I'm not sure that we can truly create a sharp divide between the two.
Do you treat, it sounds like you don't, but do you treat IgE and eosinophilia atopic dermatitis differently than, say, a patient who comes in and has normal levels of IgE, or you have the same approach?
Now, the approach is really no different. Whether we're talking about something like dupilumab targeting the Th2 axis, which can also work for those who don't have those elevations. We also, frankly, don't really understand the role that they play. What does it mean if you have a high IgE? What does it mean if your eosinophils are up? We don't really have a clear role for any of that in the pathomechanism of atopic dermatitis.
Do they have different presentations, these types of patients? Or do you see that they're more itchy or more hypersensitive, or they really present very similarly?
I think they present very similarly, other than the evidence of increase in IgEs.
And at this time, is there any specific gene that has been found to be the marker for atopic dermatitis?
Well, by far the most common gene associated is in the profilaggrin gene, and having deficits in the expression of filaggrin as a result. We know that this is by far the strongest genetic association. And we also know that individuals who have ichthyosis vulgaris or who have gene abnormalities in the profilaggrin gene have a greater risk of having atopic dermatitis. That risk is even greater if they have two abnormal copies of the profilaggrin gene, as is then their risk of developing other forms of atopy after the occurrence of atopic dermatitis, and having more severe disease with this. That said, we need to recognize, though, that the majority who have these abnormalities in profilaggrin, and particularly those with just a single gene copy that's affected, don't have atopic dermatitis.
So are they studying both the parents and the children's genes, or really just focusing on one gene? Because it sounds like it can be genetic, but it's not always genetic.
Well, again, even though the risk is much greater if one has profilaggrin abnormalities, usually where missing, it's a depletion of the profilaggrin gene expression, the decrease in filaggrin. I want to first emphasize that we don't routinely look for this genetic abnormality. It's not the way we treat. We use it as a research tool to better understand the role of filaggrin and whether there are sub-classifications that can be considered. And that is how we learn, for example, greatest severity, when one has a filaggrin deficiency, or increased risk of later going on then and having that sequence, for example, of atopic dermatitis and asthma occurring. We also know, and I think this is very important, that when you have skewing with increases in Th2 pathway cytokines and chemokines, we know that that in itself can drive down the ability to produce filaggrin. So if it's not there from the beginning with a barrier abnormality related to filaggrin deficiency, it does tend to come up with the association of the atopic dermatitis because of the impact of these cytokines on not just the expression of filaggrin, but also other proteins of differentiation and even your lipid pathways.
Do you think we'll get to the point where, a patient comes in and you're going to say, I'm going to do a blood test on you?
So the question of biomarkers does loom big. Most of the work that we've done with biomarkers has been really correlating them with disease severity or age or other factors, race, ethnicity, et cetera. However, I think that in the future, that would be the goal. It may well not be the ones that we're finding correlate with what we can see clinically or what we can capture for history. There may be others that are only done when we do big data. We may find that among the tens of thousands of genes that are derived from RNA-seq, that there are some that correlate very well with predicting responses, for example, but aren't necessarily the same ones that correlate with severity. So I think we have work to do. It takes lots of patience and longitudinal studies to make decisions that will allow us to then go back and find biomarkers that will allow for predicting responses, or certainly predicting the disease course in the future. And this is a goal that we need to keep in mind for the next few years to come.
So now that we've talked about genetics, what role does epigenetics play in atopic dermatitis? I know that environmental factors have a role. So I'm specifically talking about epigenetics here.
Sure. This is a frontier for the future. There's no question that environmental factors play a huge role, whether we're talking about anything from the whole exposure to bacteria, to exposure to irritants and allergens, to exposure even to pollution and the urban environment, and of course, stresses, what happens in life. We really don't know the answer right now to how all of these in their entirety translate into triggering the skewing of pathways, or play a role in affecting the microbial population, or play a role in breaking down the barrier further, or alternatively, encouraging it to be as normal as possible. But you hit it on the head that epigenetics is that new frontier. And hopefully by understanding that better, we may be able to control some of these influences on gene expression that come from the environment.
Fascinating. It sounds like there's a lot of research to be done, and it's already in the process, but it's a work in progress.
Absolutely.
So what is the connection between atopic dermatitis and pityriasis alba? I know like there's some crossover, and many people say pityriasis is like a subset of eczema or atopic dermatitis. What is your feeling about this, and what is the best treatment option for pityriasis alba?
Pityriasis alba is yet another example of something we see so commonly, not even that well defined, of course, but we consider it a form of post-inflammatory hypopigmentation. And we talk a lot about subclinical inflammation. I would say that this is a huge unmet need overall for dermatology, not just pediatric, understanding post-inflammatory pigment change better. What is happening biologically? What are the transcriptional changes that are occurring? And what, of course, one of the difficulties is if it relates to inflammation, it's afterwards. So there is a timeline there that if you don't capture it at the right time, it may be hard to understand. But we do understand very little, as far as I'm concerned, about this. So we can talk about pityriasis alba being subclinical inflammation, leaving behind that post-inflammatory hypopigmentation. We see it more in children who have atopic dermatitis. And of course, we can see post-inflammatory hyperpigmentation or post-inflammatory hypopigmentation as residual in our patients, including having nothing to do with topical steroid use. And we don't really understand that. When we talk about post-inflammatory change, we know it can take a while, and if we can control inflammation, that the pigment will come back on its own. There is no guideline for treatment of pityriasis alba. There's no consensus on how we take care of it. So we all have our own thing. For example, for me, I will sometimes say, I don't really know when you had this subclinical inflammation, but let's go ahead with a few weeks of some anti-inflammatory agent. That might be a topical steroid, that might be a non-steroidal alternative, and then let's just moisturize well, see what happens after that. It's an excellent question, because I would agree that understanding better this whole concept of post-inflammatory pigment change is one that deserves more research.
Especially because it's so common in children.
It's common in children. We see it in adults, of course, too.
Yeah.
Yeah.
So it sounds like you kind of just do a trial and you test a few things out, see how they work. And do you ever just kind of let it go and eventually resolves on its own?
Oh, yes, because it will. Um, I think the big question is, since we have no idea what really triggered it, we don't even know if there is truly inflammation there at the time because we can't really see it. So it just becomes empiric whether one treats or not, because what are we really treating? And I explain all of this to patients. I just want to play it safe. If there's any ongoing inflammation, let's see if we can knock that down a bit, and then move forward. How long do you treat with something anti-inflammatory? Who knows? Because there's no guidance as there might be, for example, with atopic dermatitis, where you can see the erythema. You want to bring that down, maybe go for a little bit longer, and then dial it down or stop and see how it goes with just moisturizer. So there really is no guideline. I think to have something that's more based on understanding the disease, we really need more research.
What role does diet play in atopic dermatitis? You frequently get parents that come in and say, should I put my child on a specific diet? Should I eliminate all these foods? Maybe it's causing them to flare. And I know that allergens play a big role in atopic dermatitis. I think it's actually a very unique concept to have a nutritionist, an allergist, and a dermatologist all merged into one setting, because they really are all linked together. And it's just a constant question that runs through parents' heads. What diet does it play? What role does diet play in this disease?
Well, I would say, do allergens play a major role in atopic dermatitis? If you ask John Hannafin, kind of one of the father of our understanding of atopic dermatitis, he has always preached that this is not an allergy. And in fact, a very small percentage of our patients truly note flares of their atopic dermatitis after eating certain foods. That doesn't mean that they're not allergic to foods that can manifest in a wide variety of other ways. It certainly doesn't mean that they don't have allergies, and allergies that are triggered by particular allergens. But specifically having an allergen trigger the atopic dermatitis, particularly when we're talking about foods, is a small percentage. We can see that go up when we're talking about things like dust, for example. There's no question that the dog licked and or was exposed, and the eczema flared, or rolled around in the grass, and we know that the child's allergic. So there are relationships, but I do want to stress that foods themselves, which is what these parents are talking about, are very uncommonly what's triggering the atopic dermatitis. We can do our prick test, we can do our IgE specific blood tests, and we can figure out foods that someone is sensitized to. That in itself is not even food allergy. So we have food sensitization, which no doubt is more in our patients with atopic dermatitis. A subset of that is true food allergy based on clinical history or bringing a child in and doing food challenges. And then a relatively small proportion of that is foods that truly trigger the atopic dermatitis. So when parents come in, we really have to understand what they're talking about when they talk about food allergy. We have large numbers when we have parent-reported food allergies, smaller numbers when they're physician confirmed, and then even smaller ones, and often in the subset of more severely affected children who aren't particularly responsive to topicals, that we see foods being a trigger.
So it sounds like it takes some education and explaining to really narrow down, is this a food or is it just triggering it to be worse? or is it an allergen? And that really takes a little bit extra, because I'm sure parents come into you with a long list and say, my child can't eat these 20 things.
Well, and they also say my child can't eat these 20 things, and the eczema is still here. The atopic dermatitis is still here. So we have great opportunities to teach. I will emphasize that it is a normal concept for a parent to come in and want to find a trigger, want to find something that if they simply eliminate it, the child will suddenly be relieved of all of this suffering from itch and sleep deprivation. And yet it's very difficult to find one or two triggers to eliminate. The skin is hyperreactive.
I know it might seem strange, but do you recommend bleach baths?
Yeah, I do that selectively. I've done this for a long time, based on some previous research that showed that in patients with moderate to severe disease, it can definitely be helpful. And there's no question that we have shown great improvement with the use of bleach baths selectively. I do them a minimum of twice a week. In those who are more severe, I do them daily. A small percentage cannot tolerate them. And certainly if they get infected and they have raw open skin, you have to take a break for a little bit. But I do them as maintenance, as part of a broader treatment regimen that helps because of anti-inflammatory properties. The percentage of bleach that we use has shown anti-inflammatory effects. It is theoretically, based on percentage and what happens in vitro, not going to be bactericidal, although I will tell you that it beautifully clears up crusting. And I do think that it does something. Maybe it's through the anti-inflammatory properties, maybe it's through the impact on the barrier that ultimately can reduce bacterial load.
It's very interesting because, when you mention a bleach bath to a child, they like kind of raise their eyebrows at you, like, put my child in a bleach bath. I never heard of it, but
well, I always use the word dilute, and I very slowly say, oh, it's a 0.005% solution. There's barely any there, but it seems to have some good anti-inflammatory properties. So it's easy enough, it's inexpensive. Why not add this in with everything else? And maybe we'll get some easy benefit.
Can you talk to me about how you educate patients or parents really about using steroids? Many parents are scared of steroids. They think it's going to ruin their child's skin, which of course overuse has risk and side effects. I'm just curious about how you go about educating the parents.
Yeah, well, one thing that's in my favor is that I've been doing this for a while. Mm-hmm. So I can talk about, I've been using these for decades, and when used correctly, I've never seen problems. So I have that advantage. But I do spend a lot of time talking about the fact that steroids are specifically put on the outside. They're not taken internally because that offers the advantage of being just where they need to be and not having these types of concerns that a lot of parents are concerned about, because they're just really not absorbed when used correctly to any appreciable amount that it's going to impact. I can talk about thinning of skin and almost never seeing that, and how we're going to be very careful. I spend a lot of time talking about the acute flare versus the maintenance and how they're very different. I have no concerns going up to 2 weeks, even with a class 2 steroid. And I'll often use a class 2 steroid ointment like mometasone, for example, and hit hard, especially when I first see somebody for a few weeks, and then dial down to something else. And we spend a lot of time talking about proactive management, which of course is not ever going to get somebody in trouble with any steroid side effects. And we talk about non-steroidal alternatives and mixing things up. We spend time talking about how unrealistic it is to be phobic about these, when what you're really doing in doing so is reducing your opportunity to help your child.
Is there an age at which, like, is it too young to start steroid? Is there an age at which it's too young to start steroids, or any age the baby could be a few days
I have no
old?
concerns about using steroids from the first time they come in when they're young infants, as long as we do it smartly and we do it safely. In pediatrics, it's all about safety. And you develop a relationship with families that guide them through what's the next step. I have a very busy email with patients who in between times email or use my chart. We use Epic in going back and forth. And I upfront tell them, please, I'm going to set you up for the next month, but I don't know how your child's going to respond. When I see severely affected infants who come in, and I treat them with a class 2 ointment for the first 2 weeks on their non-facial areas. And I say, after 2 weeks, I want you to go to once a day. And then I need to talk to you because I need to know your child could be one of the about 50% who do so beautifully that you barely need anything after that, except a little burst of treatment to deal with flares. Or your child may be in the 30 to 40% that may need something more chronically, or maybe even in that 10% that just isn't responding, and we've got to figure out why that is. So there are lots of different outcomes with a surprisingly high number who are quite severe, who really need very little after that, except a little burst here or there of some anti-inflammatory treatment. And I don't know that when I first see somebody. So that follow-up is very important in helping parents learn the art of maintenance, which is really where the art of treatment is.
How often do you see children outgrow their atopic dermatitis into adulthood?
I can't really tell you from my experience about that. I can tell you more from longitudinal studies that have looked at that we see the majority of children outgrow by the time they get to the second decade, and many of them by 3 years of age. The reason I can't tell you from my own is because if they're doing well, I don't see them anymore. I might have them come back for some other problem down the road. Oh, we saw you as a baby, you outgrew it and haven't had any problems since. Of course, we also do see children who do very well after the first few years and then have a flare again. I think the tendency to have atopic dermatitis, that increased risk, may be lifelong. And that's why we can see hand eczema, for example, down the road. That's why we can see a recurrence in teenage years after not having it for many years, even when severe as a baby. So there are many courses that have been well delineated now from these birth cohorts and careful longitudinal analysis. And we know that there's a large group that, particularly those who have milder disease, don't have the family history of atopy, who even with an early onset lose that by about 3 years of age, but others who pop up for the first time in childhood or adolescence or adulthood, or even when they are quite senior as adults.
Yeah, my brother has a patch/plaque on his scalp, and he never had eczema as a child, and now he's in his 30s, and it's just interesting. He's developed asthma. He's just like one of those patients who has this late onset. So when do you choose whether to use a calcineurin inhibitor or a PDE4 inhibitor? How do you choose between the two?
Well, I think that I like to give patients and families a choice. This is really shared decision-making. Both of them are wonderful options to try to reduce the need for steroids, and families, of course, love that. We've had 20 years of experience with topical calcineurin inhibitors, so we have much more long-term experience with that. I don't think anyone has concerns about the topical PDE4 inhibitors, but I will say that we've been a little bit disappointed with the tolerance of the topical calcineurin inhibitor that's out. Unfortunately, the majority of the children who've tried it on their face, which is where I most like to use it, have had some issues, at least initially, with burning and stinging, and doesn't take too long and too much of that before a child will not want to use it.
They give up.
They are not forgiving as we might be as adults. Of course, when I use either of those, I try to first use a little topical steroid, get the redness down, and then put them on, because of the increased risk when very red of having a little bit more of that feeling of heat or burning and stinging. But the majority of patients are able to transition. Sometimes they're not strong enough to get away totally from steroids. But my feeling is that if you can get off of steroids and use these as sparing agents, all the better.
So do you often do maintenance with these sparing agents, or?
I certainly like to for the face or other sensitive areas. Sometimes they're not effective enough for non-facial areas as maintenance, depending on the severity of the individual, and I'm not able to, but I like to use them as part of the regimen. That may mean, for example, that I can't effectively do proactive therapy with a topical steroid because only putting it on 2 times a week or 3 times a week, they flare. And maybe I'm able to then intercalate for those other days with a topical calcineurin inhibitor or a PDE4 inhibitor, and able to then get away with my proactive approach in a way I couldn't before. But I have many children who are just able to use something like tacrolimus and don't, except if they occasionally flare, have to go back to topical steroids, and that makes families happy. We, of course, have the latest data on the 10-year follow-up study for tacrolimus that tells us that really there doesn't seem to be any evidence from that and all the previous studies of an increased risk of lymphoma or non-melanoma skin cancer, which were the reason for the theoretical need for a black box. So we've got a black box for 20 years, no evidence of a problem. But we have to recognize also that when there's a black box, which by the way is very hard to get rid of, the pharmacist is obligated to tell the person picking it up that there may be a cancer risk. You can imagine how a parent feels about that. I've had plenty of people who say, oh, I'm not going to use that. So I never prescribe a calcineurin inhibitor without mentioning that the pharmacist may say that and giving a little more information that would reassure them that they don't have to be concerned.
Of course. Is there a movement to try to remove the black box warning? I understand it's complicated and difficult to do, but
I hope so, because it's just one more burden for us as physicians prescribing.
At what point do you recommend dupilumab?
Dupilumab?
Yeah, sorry, I froze.
Yeah, so well, we have algorithms and they're published on when to think about moving to a systemic therapy. For those who aren't doing well enough with topicals, it's an easy solution to consider a systemic. For those who are on them chronically, and particularly some of the stronger ones, I think we really have to think about if it's appropriate to go to systemics. Phototherapy, of course, is one that we've had for a long time, but I will say that if somebody's quite flared, it's not tolerated. And I just find that the time burden of phototherapy for atopic dermatitis is a real problem for families. You've got parents having to take off of work, you've got kids having to miss school. It becomes very difficult. When we think about the chemotherapeutic agents, essentially, that are out there, the immunosuppressants, like I'll start that again. When we think about the immunosuppressants that are out there, cyclosporin being the one that is probably most effective and certainly is fastest in trying to relieve patients who are severely affected. And then others like methotrexate or azathioprine or a mycophenolate mofetil. These are all options. Probably our favorite way to go if we have to use those is cyclosporin for a few months to get in that faster action. And then once things are better, trying to transition with a choice being methotrexate because it's the least immunosuppressive. It's the one that we have the most comfort with. We certainly don't want to use steroids, particularly in children. We know that they can have a great effect, but they're not practical. You can't continue for very long. When you stop them, even when you try to taper, there's often that rebound. So we virtually never will use systemic steroids in children. Dupilumab has basically changed everything. As one of my parents said, this has been a game changer for us. And it really has, because not only have we been hesitant to initiate an immunosuppressant, but then you have to convince a parent to put a child on an immunosuppressant. And I can't tell you the many, many children that I have waited a year, 2 years, sometimes even longer before putting them on an immunosuppressant to treat. And then I'm always glad later when I do, because it can turn them around in many cases. But we're so hesitant. Dupilumab is the first, and I hope there are many more to follow, giving us options to not use something that we're worried about. Of course, we don't know long-term effects, but from a theoretical standpoint, when you're very selectively targeting the Th2 pathway, or in the future, perhaps interleukin-13 or other targets, we can feel very good about safety, especially knowing that we don't even know what that pathway does other than cause allergy and handle parasitic diseases that aren't a major problem here in the United States. We don't even have to do labs. I don't get baseline labs. I don't get follow-up labs, because there's really been nothing shown other than that low risk of having the conjunctivitis. And then, of course, having to deal with a shot, which is not nothing in children, but nevertheless, dealing with a shot or sometimes having an injection site reaction. Those are really what we see. And that's a pretty low burden, pretty low risk for getting on something that can change your life. So I've had a pretty low threshold. Of course, it's only available for 6 years of age and up right now. But I'm so comfortable with it that if I can get it for someone, I do. It doesn't work for everybody. It's important to say that. But for many, it's the best we've got.
Wow. Sounds like a miracle drug at this point.
Well, it's the first. And when you're the first, it revolutionizes.
What do you think about topical JAK inhibitors? I know that's something in the works. Are they looking promising for treatment?
I can't wait for them to come out. I would say that as a safety-focused pediatric specialist, I have my concerns about the systemic ones. I will use them. I will use them very selectively. But topical, especially when they come out and show no evidence of any systemic side effects that we need to be worried about, we can ideally then get the impact of a JAK inhibitor where it needs to be without the risks. And then it becomes like the use of topical steroids instead of systemic steroids, a world of difference, and something that we're quite comfortable with. So I'm hoping that they're quite effective, that they don't cause burning or stinging. And so far, we've got some good evidence in trials that that will be the case.
Are you working on any of those trials at Northwestern on JAK inhibitors?
We've been involved, and we've also been involved, or will be involved, with some of the other trials. It's not the only topical that may be coming out over the next several years.
So a few more questions before we close. I've heard and kind of dabbled in some research on fecal transplants for atopic dermatitis and treating bacterial infections of the skin. What are your thoughts on fecal transplants for atopic dermatitis?
Well, the whole concept of the microbiome is so exciting, and one that we could spend another hour talking about in itself. It remains to be seen how manipulating the microbiome will or will not make a difference here. I would say that fecal transplants are something that have been life-saving for certain disorders where we really need to shift the bacterial skewing towards bad organisms. I think that their role for autoimmune disease is under investigation. I don't think we're quite ready to mainstream fecal transplants here for atopic dermatitis. We got a lot of other, probably better options, but it really does raise the possibility of changing the gut microbiome as a way to change the skin microbiome and effect change in the systemic immune system. So I wouldn't rule it out for severely affected patients for whom we have no other recourse right now. We're not getting someplace, but it certainly would be for the rare exception until we understand more.
And it sounds like at this point we have some other treatment options for those
We
those
have lots
classes
of other
patients.
treatment options coming out, including changing the microbiome topically. Unfortunately, the Roseamonas mucosa trial just shared its phase 2 data, and in this double-blind randomized trial did not show enough significance to move forward. But we still have topical studies with Staph hominis, for example, that hopefully will come out soon, and we'll see how that does. And more to come.
So where do you see the future of atopic dermatitis advancements and therapeutics and research going?
Well, I think that there's so much more research to be done. We've talked about several areas where we've made huge discoveries in terms of understanding. I'm doing a lot of research right now, for example, on the lipidomics of atopic dermatitis and other disorders, and there's much to learn there. We've found all kinds of changes that have never been reported, and we'll be working on that over the next few years for sure. I think that just understanding, as you talked about, the epigenetic factors, trying to understand how these drugs work and their safety for the future. How do you decide which one, once we get a candy store, to choose for which patient is always a question. And just understanding more about that interplay between, or rather among the microbiome, the barrier, and the immune changes will take us a while to understand. Finally, how we can alter the course of development of other atopic disorders will be a huge question and that deserves investigation. I think we're just at the tip of the iceberg for coming out with new treatments, but there's no question, if we look at what happened with biologics and psoriasis, this too will come for atopic dermatitis. It's already well on its way. And having oral medicines, whether they be JAK inhibitors or others that come out that maybe aren't quite as effective, but don't have some baggage related to them, so they will enter our armamentarium. All of this will basically give us a picture 10 years from now that's very different now in terms of the struggles. I think we're getting a glimpse of it in terms of our many patients now who are just seeing us by telemedicine in follow-up for their dupilumab.
Wow. Very exciting and amazing times to come. And we're already witnessing that. So thank you, Dr. Paller, for sharing with us your knowledge about atopic dermatitis and for giving us a very extensive overview about what atopic dermatitis is and about the research going on. This was a fascinating conversation, and I hope everyone enjoyed it and got something out of it. I certainly did, and I really appreciated talking to you today.
My pleasure. We'll do it again sometime.
I hope you enjoyed this episode of the Derm Club podcast. If you found the discussion today to be valuable, please subscribe and share. I look forward to seeing you in the next episode as we continue to delve into dermatology and skincare with the world experts.